Suman, welcome you all in our today's discussion. Today we will discuss regarding a very burning issues, that is the triple negative breast cancer or BRCA positive breast cancer, how we can treat and how the novel development can help us in guiding our total treatment. Thankfully we have got our opinion leaders of Bangladesh, I must say, Professor M.A. Heiser, Chairman of Oncology Club. We do have Professor Mofazul Hossain sir, Chief Consultant, Medical Oncology, BRB Hospital. Dr. Parveen Akhtar Banu Madam, Senior Consultant and Director of Oncology Unit, Labit Cancer Hospital. Dr. F.M. Kamaluddin sir, Associate Professor, Radiation Oncology, National Institute of ENT. Dr. Shahida Alam, Associate Professor, Radiation Oncology, NICRH. So thank you all the respected persons for giving their very precious time. So as usual, we will start with a case scenario. This is a 45 years premenopausal woman. Clinically T3, 5.1 centimeter lump in breast, lymph node positive, immunohistochemistry, triple negative breast cancer. So T3N1M0, TNBC. So my first question to Dr. Shahida Alam Lima, how you will approach to this patient? So for making your life easy, I am giving you options. You just say yes or no. So would you proceed with neoadjuvant chemotherapy?
Okay. So first of all, thanks the organizer for this opportunity, and I'm really honored to be a part of the system panel. So to answer your question, I would definitely go for neoadjuvant chemotherapy.
So thank you, Appa. Next question. Would you add platinum to neoadjuvant chemotherapy? Yes or no?
So it has been a burning question for a long time, but I think after the result of the brightness trial, this question has been answered. So definitely after this result, I would love to add carboplatin in the neoadjuvant setting with conventional ACT protocol.
Okay, so your answer is yes, right?
Yes.
Okay. So third question, would you consider checkpoint inhibitors as neoadjuvant chemotherapy?
At this point of time, I think no.
Okay, thank you. So Dr. F.M. Kamaluddin sir, are you agreed with all these answers, or you do have different opinions in any stem of these answers?
I think, thanks, Suman. I mean, at this point, there is enough data to be with her. There is no conflicting data to disagree. So I'm totally with her to give neoadjuvant with platinum doublet, but not to think about checkpoint inhibitor at this point. So
Parveen Akhtar Banu Madam, so what's your opinion regarding these three answers?
Just a minute. Sorry, regarding the, another combination you didn't ask. I don't know. Are you bringing the later on some more options?
Okay, wait.
Okay,
this is just an appetizer. Okay, please.
Thank you very much, Dr. Suman, for asking me. And definitely, I will go for neoadjuvant chemotherapy for this TNBC locally advanced patient. And platinum, yes, I may add platinum because platinum will increase the PET CR, but there is a lot of toxicities also, hematological toxicities. So high risk patient, yes, I can add. And checkpoint inhibitor, I don't think at this moment I will add, but there are trials both in early and advanced TNBC, like Impassion non-30 and Keynote 522. I think there is early and both cases they have added checkpoint inhibitor with good result, but I have to think about it in adding checkpoint inhibitor.
So Kamal sir, you have raised your hand. Please proceed.
So regarding the IO in neoadjuvant setup, there is a classical 10% higher PET-CR. So I want to say that we can always discuss with the patient that whether the patient is agreeable for that in neoadjuvant setup, number one. The challenge is the availability and the cost. But there are a strong believer that 10% addition of PET-CR, and when you have meta-analysis of survival benefit of the PET-CR, so this is we will not say that we will give or will not give, but I think it should be in the table of discussion with the patient that there is an option by using immunotherapy at the neoadjuvant setup in TNBC, which can give you additional 10% PET-CR benefit.
Sir, Kamal Bhai, to add with you-
Lima, just a minute. So today our total intention is quite different.
Okay.
So theoretically, I have add these issues, but today our total discussion will be on different topics. So IO is not our topic. So I think we should stop our discussion regarding the IO issues. Mufaddal sir, what's your opinion regarding these three answers?
Well, about the first question, definitely I'll go for neoadjuvant chemotherapy. There is no doubt about that. And the other members of the panel have also opined in the same way that I am giving now my opinion. Well, about the platinum, yes, I usually add platinum in the second phase of the chemotherapy, initially either AC or AC followed by Pacli plus Carbo, because as Dr. Parveen Akhtar Banu said, it increases CR rate, PCR rate. And about the checkpoint inhibitors, changing inhibition to neoadjuvant chemotherapy, yes, there are studies which say that if it is triple negative, it improves, but the cost has always been an issue, and most of our patients cannot bear the expenses. So at this point of time, I will not add this checkpoint inhibitor, but the options will be definitely discussed with the patients, and if they can, I will definitely do that. Since it is triple negative and stays almost 3, it is near 3. It is 2B or
3A.
3A.
So I will discuss, and if they can afford, I will try to add the checkpoint inhibitor.
So thank you, sir. So as discussed, the patient treated with 4AC, 4-paclitaxel as neoadjuvant chemotherapy. She was not offered carboplatin, and mastectomy was done, and it comes with YPT2, so residual disease 2.5 cm mass is there, N1, 3 out of 11 lymph nodes positive, and after that she received radiotherapy. Now, the patient's triple negative breast cancer, not a very good respondent group, residual disease. Now, Lima Appa, how you will going to treat your patient right now?
So I will answer one by one. First, adjuvant capecitabine. So as of now, the data is in favor of adjuvant capecitabine according to the CREATEX trial in unselected patient. If the patient is not any biomarker test is positive, I'm coming to that point later. So capecitabine now the standard of care for the patient who didn't have PET-CR. The second is adjuvant platinum. Yes, there is a trial which compare adjuvant platinum with capecitabine, but that was a negative trial. So that didn't show any benefit of using platinum or in comparison to capecitabine. And the third is adjuvant immunocheckpoint inhibitor. No, if the patient didn't get the immunocheckpoint inhibitor in the neoadjuvant setting, there is no data to support to add is in an adjuvant setting. And second, close observation, no, not at all. But I want to add something that I will go for BRCA1 testing for this patient.
I'll come to later. So your answer is answer 1, right? You are within
yes,
number 1.
Unselected patient, I would go for adjuvant capecitabine for 6 to 8 cycles.
Okay. So Kamal Bhai, are you with it?
Yeah, because till now this is the gold standard recommendation.
Banu Appa, are you with it?
Adjuvant capecitabine, there is I use a lot, but I have seen last ASCO or 2019, given capecitabine could not show a good result in all TNBC. There are subset like basal type TNBC, in which it has shown overall and disease-free survival benefit only, not all patients. So
Right.
we have to think about it. And adjuvant platinum, again, there is subset of patients like BRCA positive patients in TNBC. They don't show much response to platinum. And checkpoint inhibitor, as I have mentioned, not at this point, but I may give capecitabine in case of non-complete PET-CR, residual tumor. Yeah.
Thank you, madam. So Mofazzal sir, I just want to ask the question in a different way. So
Yes.
PATX trial, total dose 2,500 milligram per meter square. In Bangladeshi populations, you are a very seasoned medical oncologist. So do you think this type of dose can be absorbed by our patients? So is it possible, sir?
Yes, it is possible. 2,500 milligram per meter square is a standard dose, and I begin with the standard dose. If the patient does not tolerate, then I go one step down. I mean, maybe 25% reduction in dose. If the patient develops severe mucositis, diarrhea, then I reduce the dose. Otherwise, when the patient develops grade 3 or 4 hand-foot syndrome, then also I reduce the dose. Otherwise, I start with the standard dose. For example, today I have a patient who is receiving oxaliplatin, though it is a colon cancer patient. He received capecitabine and oxaliplatin about 2 years back. Then he had relapsed. I tried with bevacizumab and FOLFIRI, but it didn't do much of benefit to the patient. So I am going back to the original one, which was given about 2 years back. So I am starting the doses around as per his body surface area. It comes 130 milligram or 50 milligram BD. I have started with 3 plus 3. I said, your dose is this, so I will start with this. If you develop symptoms or toxicity, then I will reduce the dose. Otherwise, I am not in favor of starting with a low dose if the patient is physically fit.
Okay. So, sir, you are in favor with the adjuvant capecitabine, particularly for this case?
Yes, I do it. I practice it also.
Thank you, sir. So, Limappa, this is the trial. That is the CREATEX. You can see the 3 years overall survival. There is 5 years data, but I intentionally put it the 3 years data, that 82.8% in the total intention to treat group, there is free survival. So we will talk with this data. So keep it in mind that the 3 years disease free survival data is 82.8%. And just for a recap, we need to highlight the patient selection group. You can see the patient group, the T2, 2 centimeter to 5 centimeter is 55.2%. So majority of patient is the T2 group. ERPR positive group, 68.6. Lymph node 4, N2 disease, 23%. And most interestingly, around 27% did not need any radiation therapy. So in the CREATEX trial, we can get an idea the patients are not a very high risk group of patients. Majority of patients are not in a very high group of patients. So keep it in mind, we discuss these issues later on. So I'm sure Limappa was very keen to jump in these issues. So Limappa, would you treat differently if BRCA mutation found positive? This patient,
Yes.
BRCA positive, how would you treat?
It is TNBC or hormone receptor positive? It can be both, no?
TNBC, the same
TNBC.
case.
Yes, TNBC. So it has been found that if the patient is BRCA mutated, then the risk of recurrence is much more higher than the same stage patient who is not BRCA mutated. And this effect of BRCA mutation is much more obvious in hormone receptor positive tumors. So Yes, I would treat differently about if the BRCA found mutated.
What would be your approach? How you will going to treat the BRCA status found
So
positive?
this patient, for this
Yes.
patient,
Yes.
so that according to the recent trial, which is just published, but not in the Lancet, but not in the consensus guideline, this recommendation. But I think in the coming year, this will be the practice changing. I would love to add the adjuvant olaparib for 1 year for this patient.
So you are in favor of adding adjuvant PARP inhibitors, okay,
Yes.
instead of capecitabine.
Capecitabine.
Okay. So Kamal bhai, what would be your decision?
So I want to supplement to Shahida that after this publication, already NCCN and SQS revised their guideline.
Yeah.
They have already incorporated the moment FDA approved,
Okay.
and they have already incorporated the guideline. So it is already in the guideline. We don't need to wait for a few months.
Long.
So this is number one. Number two, yes, Shumon, this is a great opportunity because if you look at the result of the OS and DFS, the hazard ratio are so impressive. I mean, so there is every valid reason to recommend if it is a BRCA 1 or 2 mutant that we must offer 1 year olaparib because it has given a wonderful survival benefit both in OS and DFS, and most important is it is a huge population, and look at the hazard, that is quite impressive. And even it was a pharma-sponsored study, but they have strictly maintained the quality of the study. So it is quite an impressive study to convince you adequately
About
that
1,836 patients is a huge
So Kamal bhai, you are ready to change your practice. So
yes.
Okay.
Yes, so, I know. I mean, the question may come with the comparison of capecitabine and olaparib. So then if it is not this specific case, then we need to discuss case by case, because this study was intentionally designed for high risk group. But the Createx was not for that. And in Createx, we have seen that TNBC was doing better than overall, and that we extrapolated and we are using. So in our context, if it is a high risk group, I will just go for PARP. But if it is not a high risk group, we will think of both the thing. And again, if the patient cannot afford, we need to go back to capecitabine. So we cannot forget the old friend, but we need to think about that.
So Shumon, one thing, this Olympia trial is biomarker driven trial, which was Createx was not that, but there is no subset with BRCA1-2 mutation or not. They just give result of each and every one, not specifically for BRCA1-2 mutation patient.
So, but in response to this, Shumon, I want to tell that if you look at the metastatic setup comparison of olaparib, it have shown that there was no significant difference of response of olaparib irrespective of BRCA mutation. So it is, we don't know what will happen in neoadjuvant, but you know, all things came from Olympia, came from Olympiad. So from metastatic to neoadjuvant. But if you look at the comparison there, 50% of the chemotherapy arm in the Olympiad was having capecitabine, and they have seen that BRCA mutation has no impact. So in the, we can extrapolate that data, and we may say that it may not have an impact on that.
Okay, Kamal, I will come later in the metastatic setup. So Parveen madam.
Yes, thank you. Yes, in TNBC, if there is BRCA mutated patients, BRCA1, 2 or both, I will favor adding PARP inhibitor. Yeah, sure.
Thank you, madam. So
Yes.
Mofadjul sir. Are you ready to change your practice right now?
In BRCA1 mutant group, yes, I will add it if the patient can afford, because always the question is affordability in our setup. Because if it is given, it has to be given about a year.
Yeah.
Okay. So an adjuvant, even it can be given as neoadjuvant if the TNBC and BRCA1, as we are talking about the Olympia trial, 1800 patients, they have shown 3 years disease-free survival compared to placebo, 86% versus 77%, irrespective of hormone receptor status, but our one is TNBC. So they qualify more to be in this group, and so I'll try to add if the patient can afford.
So thank you, sir. Thank you. So
But
we
I have
all
not-
are in
I have
favor of
not
change our
practiced
practice.
in any of the cases. So that is the problem.
So
sir.
financial fitness is the main concern.
Yes,
Yes.
yes.
Otherwise, scientifically, we all are agreed.
Yes, yes. We agree that the
Previously,
most.
even previously, BRC1, BRC2 testing used to cost 35,000 taka.
Yeah.
Now
Yes,
it is 15,000 taka only. It is
Right.
because of our pressure that has compelled the laboratories to reduce their profit, right?
Right, sir. Right, sir. So let's see. That is the brightness trial. Limapa already mentioned. That is the neoadjuvant setup. You could see the paclitaxel, paclitaxel carboplatin, and paclitaxel only. You could see that adding velaparib with paclicarbo did not produce any pathological response rate. So it was a negative trial. But when you can compare with the JPER-6 trial, that is the platinum combination, with the PARP inhibitors, that is by the brightness trial, you could see that the BRCA mutated group good responded with platinum. And in the velaparib combination arm, you could see the BRCA mutated group produced a better PCR. So this brightness trial gives some brightness in the dark area. And you could see that a very interesting paper that the talazoparib is the single arm PARP inhibitor, 6 months neoadjuvant after surgery.
Before surgery.
You will be very amazed to see the findings. Before surgery, neoadjuvant, 6 months talazoparib only, no chemotherapy. The complete pathological response rate is 50%. So these are the trials that gives the light that the PARP inhibitors can be a good player in the coming lines. So here comes the Olympia. Time for change. This is the question mark still there. So in this year, the ESCO publication, ESCO meeting, it comes, and you could see that the patient selection group was HER2 negative. Both TNBC and hormone positive tumors are enrolled. But in the TNBC subgroup, if they receive neoadjuvant chemotherapy, if no pathological response rate, no PCR, she can be enrolled. But if she received adjuvant chemotherapy, the criteria is either she should be N1 disease or pathological T2 disease. So this is a very high quality selection criteria. But those are hormone positive. You could see there the selection criteria is quite rich. You could see that if the patient received neoadjuvant chemotherapy, no PCR, and combined clinical pathological score with EGS score more than 3. And if she received prior adjuvant therapy, the lymph node should be more than 4. That is the N2 disease. So the criteria here for TNBC is quite a bit lower than the hormone positive disease. So for our recall, we just want to mention the CPS EGS score. You could see the CPS EGS score is the clinical stage combined with pathological score and tumor markers, ER-positive grade 3 score. So combined, the total score is 6. So they have included that the score should be more than 3. So these are the baseline characteristics. You could see that the more the patients are BRCA mutated, BRCA1, and around 28% is of BRCA2. And all the combinations chemotherapy are given there, including the platinum. Premenopausal, postmenopausal, almost 60%, 40%. And here you could see the invasive disease-free survival, that is the primary endpoint. At 3 years, 36 months, 85.9 versus 77. Intentionally, I said earlier to mention the CREATEX trial. You could see that here in the Olympia trial, the patient selection criteria is quite poorer subgroups. And even with these groups, you could see the 3 years disease-free survival, invasive disease survival is better than the CREATEX. So it's a very tempting result, definitely. And as already mentioned by you, the panelists, that the hazard ratio is very interesting. So here you could see the very interesting findings that all subgroups, you could see that olaparib is better. Most interestingly, I should say, as the patient presented with better poor criteria, and you could see that score 5 and 6, CPS EG score CP 5 and 6. You could see the hazard ratio is better. So as the patient tend to metastatically very prone, those are very high risk, you could see that olaparib are going to produce better outcome for this subgroups. So this is a very interesting idea and very interesting information from this subgroup analysis. Regarding the distant disease-free survival, that the metastatic-free survival, they are also very interesting, that the total difference is around 7%, so 80.4 versus 87.5. And we should keep it in mind that the subgroup is very risky subgroups. And overall survival, it is not yet to conclude, though it is not statistically significant. Only 25 months median follow-up has completed. So they are not very keen to analysis with the overall survival. So we are right now discussing on the IDFS and metastatic free survival. Regarding the toxicities, this is very well tolerated. Nothing, what I should say, nothing sensitive toxicities found over there. And regarding the safety criteria, I should say the olaparib can be easily given to our patients. So at last, the Olympia trial concluded that the BRCA mutated group, this can be a good, better option. Even in the hormone positive group, this can be a good option. But overall survival still not come to give a conclusions. So now the very important question. So as we have got our opinion leaders over there, so we need to discuss it in a very critical way. So I just want to show you the graphs. You could see the disease-free survival. This curve starts to divide it very earlier. And from a pharmacoanalytical point of view, it showed that PARP starts to act on 45 days. So this is the curve starts from very early. So why we should give 1 year? So can we cut down a bit lower? So instead of 1 year, can we make it a shorter duration? Mofadzul sir first. Sir, can you hear me, sir? Probably sir is not in line. So Piabanu madam, what do you think?
No, I'm very much in the line.
Okay, sir. Okay,
Yes,
please.
sir.
Right. The study has shown a follow-up of 3 years. Okay. So after giving 1 year, they have followed up to 3 years, and the disease-free survival has been quite impressive. So at this time, I think we should continue to give, if at all, for 1 year. If further studies and some other new studies confirm that it can be given, even as the case of Herceptin, 1 year versus 2 years, then 6 months, non-inferiority. So eventually we will come to know whether shorter duration will be of similar efficacy or not. But at this point of time, I will stick to 1 year because
Okay,
I
so
have the data in support of 1 year.
okay, sir. So you are with the Olympia trial protocol. My next question to Piavano madam. So here you can see that Olympia trial in the hormone positive group, in the adjuvant setting, if it is lymph node 4, then it is included in the trial. So what will happen? Those patients, those with in lymph node 3, still she is in high group, but Olympia trial didn't include her in the study. So what to do with this 3 lymph nodes patient?
If other high risk factors are there, then we can, but trial has not included that patient, then we can go with that is hormone receptor positive, so we can treat in that line.
Okay. So Kamal bhai, what your intake? These are the limitations of this Olympus study, because I cannot clearly mentioned this area. So how to address this area?
Suman, first of all, I want to say that, you see, we all are happy that we are changing our practice and everything, but it is the accelerated approval. It is, we have not yet, the CARB is separating, but the OS we are waiting. So this is, I mean, too early to make so many comments on these things. I think, you know, if you look at the strategy, what they have done, from metastatic, they have taken the high risk group. Slowly they will move. And still they are trying with neoadjuvant, and there are, you have shown one, there are few other studies already in combination. They have some promise in neoadjuvant, but still it is not in the recommendation. So I think till now we need to stick to the evidence, because it is a completely a novel approach. We should not do our own experiment. Rather, we can expect that somebody in the sub part of the world, they will be doing some experiment to bring down the duration. But you have shown that the CPS score, when it is more effective. So the question may come that maybe in less, it may not be effective, one. I would be happy if it was effective in PCR group, because the most challenging part is the recurrence after PCR. In TNBC, we get 50%, 45% PCR, but when the patient relapses after PCR, that becomes a big challenge for the oncologist. So sometimes that low risk group is also a challenge. So I will say that regarding duration, in adjuvant setup, I mean, unless you have enough evidence, and this type of PARP, you have seen that they go for long. So we don't have enough experience with PARP in adjuvant. This is probably the first adjuvant experience we are going to have with PARP. Always we are having in metastatic setup, and it was giving some recurrence, reduction of recurrence, and they are always 2 years. So this is minimum till now. So I'm not courageous to reduce it. And regarding the risk group, we can assume that it will not be as effective like that, because you have shown CPS score 3 and plus, and more the CPS score, better the response. So probably there will be less response, but we need to wait for more mature data to come. And regarding the good prognostic data, till now, definitely we can avoid, because we have no data to give it. Rather, I will say if we give, it will be overkill without any evidence. And I will be cautious to give, because this is an expensive drug. And the funny thing, interesting thing is this data, this total trial have shown a very interesting side effect profile, which is very much comparable to placebo, which we have never seen in other PARP trial. There we had to go down for many things. Another interesting in this explanation, they have shown that using platinum or not using platinum didn't affect the outcome of this adjuvant. That is another very interesting observation. So I think there are few more questions to be answered in this study, and with longer time, we will be getting some more answers.
Limapa, regarding
Yes.
these three questions, do you have any
So regarding the
observation,
first
any
question,
suggestions?
I would like to go by the trial design, that is 1 year. So Sir is very right, Mufaddal sir, maybe in the coming year, more trials will become with like after the HERA trial of 1 year of trastuzumab, 2 year, 6 months, comparing inferiority, non-inferiority trials. So till that, I would like to go for 1 year, okay, according to the Olympia trial. And your second question, you can, if you look at the trial design, they have included a very different, diverse group of population, no, hormone receptor positive, negative, neoadjuvant, adjuvant. So, and they are very correct. In hormone receptor positive tumor, a long time they are considered to be a low risk comparing TNBC or HER2 positive. Okay, but if you look at the control group, that is the patient that received the placebo, in that group, these 4 positive or the patient who received the neoadjuvant but not PCR, this 23% of patient had disease recurrence or death. So any disease that produces more than 20% risk of recurrence, that should be considered. So these are actually the high risk patient of hormone receptor positive, not the other group, that 1 or 3. Am I right? Can I clearly mention the thing that 23% patient who are 4 lymph node positive, they had disease recurrence or death. So they are really high risk patient. So we should offer the drug to high risk patient, not all patient. And we should not remember, forget one thing, that the PARP inhibitor is a DNA interactive drug. So they can produce DNA mutation and later on hematological malignancy, and myelodysplastic syndrome. Though this paper Olympia, they address this issue, but 2.5 years of follow-up is not enough to address this long-term side effect. So I think at this point of time, we should not offer this patient to good prognostic BRCA positive patient.
So Limapa raised a very important issues regarding the toxicity issues, though the Olympia didn't face any problem, but we know from our previous experience from the ovarian issues, there are myelodysplastic and leukomic issues. So I think that should be the issue. And the number three, probably there will be time come, chemotherapy obsolete, and so single pill instead of chemotherapy. So let us wait for the time. So I am not sure, is this the time for change from Zeloda to PARP inhibitors? So all our panelists are agreed. If the patient are in a proper shape, proper selection criteria is there, they are in favor of on this party. So this is all about this adjuvant setup. This is the all Olympia trial. Now come the second question, second scenario. This is the premenopausal lady, T2, N1, M1, TNBC, BRCA positive. So first line, metastatic setup, docetaxel, 12 months progression-free survival. After that, 8 months PFS. Now disease progress. How you are going to treat your patients, Limapa?
So your patient already got
Limapa, can you hear
in
me?
the first line and in the second line. Yes, yes. So you have already given docetaxel in the first line, no, for this patient with BRCA1 positive TNBC patient with metastatic setup. But you know, I'm a very big fan of TNT trial that shows that in the BRCA positive subgroup, using carboplatin single agent had the almost double overall response rate, that is 68%, which was 33% for docetaxel, and the progression-free survival was 6.8 months. So I'm very tempted to use carboplatin in this group of patients first. Okay, and then after that, if disease progression, I would like to go sequential single agent like eribulin, it may be eribulin, maybe capecitabine, maybe vinorelbine.
Okay, so regarding the third line,
third line. So I have option of using carboplatin first. So I would like to give carboplatin in the third line.
Okay, so Limapa, intentionally I have raised these issues at the first line, the docetaxel in BRCA positive group. So you are very rightly mentioned that the TNT trial showed that the BRCA positive group docetaxel carboplatin produced almost double response rate instead of docetaxel. But very interestingly, I have to add that those who are not BRCA mutated but triple negative subgroups, the docetaxel and carboplatin produce equal outcome in the TNT analysis. So not only, we should not focus only on the BRCA positive subgroups. So carboplatin, a very cheaper drugs, produce equal outcome even without a BRCA status mutation. So in triple negative breast cancer, we should consider carboplatin is a very potent drug. So regarding these third line issues, that is our main topics. Now what you will do? Suppose this patient docetaxel, eribulin has already spared. So now what to do in third line?
I would go for carboplatin.
So carboplatin, still you are not in favor of PARP inhibitors?
No, not now, because carboplatin, PARP from the Olympia trial, the PARP inhibitor also showed the same type of benefit, like 68% overall response rate and 7 months of disease-free survival. So if I can get the same result with a cheaper drug carboplatin, why should I go for this Olympia trial, like this olaparib in the third line?
Thank you, Appa. Kamal bhai.
I want to go back to our previous discussion 1 minute, that the hormone receptor status was discussed. So you see in this Olympia paper, in the discussion part, they have mentioned, even they have not included the ER positive group, but in the neoadjuvant setup study design, they have seen that using PARP along with hormone receptor was not a conflict. So they are taking it that, as Shahida correctly said, that even in hormone receptor positive, this 20% plus group is getting recurrence. So it is a high risk group. So maybe at the beginning they may involve it, but there is rationale to bring up PARP for ER positive high risk group also, because in the neoadjuvant setup, they have tried it and there was no conflict. So coming back to this question, yes, there is no head-to-head comparison between TNT and Olympiad, but Embraca. But if you look at the survival figure, it will find that probably it is almost similar. So it is 30 plus and 60 plus is the outcome. So I want to try with platinum first and then keep PARP for future, not to exhaust expensive drug first.
So just a issue to discuss. So Kamal, first line docetaxel in metastatic setup, second line eribulin. So do you think that performance status can be an issue for considering this platinum versus PARP?
Yes, that is an issue. But you know, Shumon, we have many options for platinum. Platinum, we don't need to give full dose. We can give weekly up to, and we can modify. And same time, when the patient is exhausted, how they are exhausted? They are mostly exhausted by bone marrow reserve. And one of the reasons for withdrawal of drug in the Olympia trial, you will see, is the anemia and hematological toxicity. So PARP is not a very safe drug also for the exhausted patient. So yes, we should be concerned. We can modify the dose. We can go for weekly regime, but we can keep in mind, but we can start with the cheaper option.
But I think we are unnecessarily scared of carboplatin. Our real data is not that scary, no?
No, but the thing is that we don't know. Platinum thrombocytopenia, if happens, it is very risky to manage.
Yeah.
We know that, but the challenge, I mean, the debate here is that if you look at the response rate, we have a good option that we should explore. We have a new drug, and I always think that for this type of patient, we should not exhaust all our resources. We need to keep more and more for future, because we don't know how long she is going to survive, and we need to offer something.
Thank you. Madam, so are you in favor of carboplatin or anything else?
After all these lines, there will be a lot of toxicities, I think. And platinum is also having hematological and neuropathy issues. So I may think of PARP if patient can afford it. If not, then platinum. Yeah.
Madam, why only platinum? There are
Platinum or
different
binaural wine also I can use.
Yeah. Yes, sir. So why we are focused only on platinum?
Yeah,
okay.
yeah.
But
Binaural wine is also a good drug for third line also may be given.
Okay.
Yeah.
So let's hear from
Binaural bean have a more hematological toxicity.
Yeah.
To
Also
platinum.
neuropathy. Yeah, that's right.
So that is a worry sometimes for binaural. It's a wonderful drug, but in a patient who is exhausted, going through this journey, binaural bean, you know, it's a very high potent of hematological toxicity.
So definitely in this situation, I think the patient selection criteria might be the major issues. So what type of drugs he or she can be tolerated, that might be the major issues. So let's hear from Mofajjal Hossain sir. Sir, what you will do in this setup, third line?
Okay, first line, I have some observation on the first line.
Yes,
6 cycles docetaxel. I would have not done with the docetaxel if the liver function is deranged, because every metastatic disease is not same. Some has bone mets, some have lung mets, some have liver mets. If the liver mets are also 1 or 2 lesions only, no hepatic dysfunction, then probably we will be using docetaxel. But again, docetaxel and carboplatin could be a good choice, because in TNBC carboplatin role of platinum is there. So first line, I have some observation about that. Not only single docetaxel, I will use some combinations, maybe docetaxel plus carboplatin, better paclitaxel plus carboplatin. Right. The second line, I will not use eribulin. I will keep eribulin later in the later lines. In the second line, if the patient has not received carboplatin in the first line, then I will have gemcitabine and carboplatin in the second line. This is a good combination, and most of our patients tolerate well, except that the platelet count which go down in the later cycles. In the third line, okay, I think this is here comes the role of the PARP inhibitors, as the patient is BRCA1 positive. And the progression is there after first line and second line. We can always think of PARP inhibitor in the third line. But if the patient cannot afford, then we'll have other choice, single drug, not combination here. Usually, as the previous speaker said, maybe vinorelbine,
Thank you.
maybe
Thank you, sir.
eribulin. If not already received eribulin, then it can be in the third line also.
So thank you, sir. Thank you for sharing your experience, sir. So you are in favor of combination chemotherapy from the very first line. So all the
Yes.
guidelines are saying that they are suggesting to use single agent chemotherapy for in the metastatic setup only for the visceral issues. They are suggesting for giving the combination chemotherapy. So what's your experience with this combination chemotherapy, sir? Patient can tolerate.
I usually use combination chemotherapy in the first line if the patient is of good performance status. Then I usually use the combinations, because in the later settings they do not tolerate combination. These are the places when second line, third line question comes, then probably single line chemotherapy is a better choice. That is what I do.
Thank you, sir. So this is the discussion. What we have found that the platinum regimen is the preferred option in the BRCA status group. So here comes the Olympiad and EMBRACA trial. Olympiad, olaparib, BD dose, EMBRACA, talazoparib, single dose. And in the Olympiad trial, they have enrolled the patient less than two lines, and the EMBRACA, they included third lines. So all you could find that progression-free survival 7 months versus 4.2 months, 8.6 months versus 5.6 months. So around 3 months progression-free survival with this part B. But the very interesting findings. So again, I go back to these lines. So BRCA positive. So that the Olympia trial showed us that you could see those who didn't receive any prior chemotherapy, the progression-free survival, the overall survival is 22.6 months versus 14.7 months. And those who received prior chemotherapy, you could see hardly you could find any difference. So here, this study clearly showed that patient responded very well if we initiated PARP earlier than the chemotherapy. So why not to use this PARP before the first line chemotherapy, sir? Mofazul, sir.
Yes, at this point, olaparib is approved by the FDA for metastatic breast cancer who already received chemotherapy in neoadjuvant or adjuvant or even metastatic setup, not as first line. So I will, like a obedient child, I will be complying with the
Go by the
FDA people, right?
But the study shows a very, very different picture, sir. So that's why I am asking you to give us the right direction.
This study had some limitations also. If you
Every study has some
if you look at the inclusion criteria in the physician choice chemotherapy, they didn't include the carboplatin. Okay, the capecitabine, vinorelbine, and another one is eribulin, but they didn't include this carboplatin. I think if they included that carboplatin, the result would be different. In the first line, the same result like TNT.
Limapa, I am coming back to your question right now, but because the carboplatin might not be the player, because the TNT, Olympiad, EMBRACA all shows that the progression-free survival, all the response rate are quite similar with this carboplatin. So yes, there is a hype with the carboplatin, but at last they have concluded that it improves the PCR, but ultimately overall survival, there is some
no
debate,
difference.
still there is. Yeah, so the carboplatin is a hype drugs, I think, in the TNT triple negative concept. So I comment later. But regarding these issues, madam, so here clearly it shows that PARP, if we initiated earlier, produce better overall survival. So why not to use earlier with a very good drug, single pill?
Thank you.
Yes,
after this observation, now there may be another trial, in the using PARP in the first line in the metastatic breast cancer. But this trial, after this trial, it showed that patients who did not receive any prior chemotherapy, they are better candidates to start in first line PARP inhibitor. So this is observation, and from this, yeah, it can be used in the first line, but there should be another trial. I think after that we can take decision.
Thank you. Kamal bhai, how to address this analysis?
Come on,
How
I
to
mean,
interpret?
these are observation, but this is not a conclusion. And
Yes.
when you have multiple options for a metastatic setup, then the question comes sequencing, then how you sequence. So if you look at the prostate cancer, there was a big debate. Shall we use docetaxel fast, or we use this abiraterone fast, enzalutamide fast? Initially, they were thinking that sequencing will be issue. Now the time has come, they're combining together. So I think, as our senior colleague, Professor Mufazzal said, as an obedient student, we need to stick to the published data. But yes, maybe as Professor Banu or Dr. Banu Madam said, this can instigate some study to look at that which sequence is doing better. But you know, Shumon, the problem with this type of study is, after so many information, they are giving only 2 to 3.3 months PFS benefit. Both TNT, Embraca, and this Olympiad. So we are not getting a huge thing there. So by sequencing upfront and downfront, what we are going to gain, we don't know. Rather, I think till now, we need to go to the data and also the fitness of the patient, whom to select for what, and the cost. So we need to think so many things. It is out of the pocket. So thinking of PARP, if the patient is fit and there is an indication for chemotherapy, definitely we should go for chemotherapy first, because we know when to stop. With PARP, we don't know when to stop. So there are many issues, and with all these things, we need to go by evidence and also the availability and affordability. All this combination we need.
Thank you, Kamal bhai. Limapa, I just landed my last slide. So you were in very favor with this platinum issues. So that's why this slide is for you. You could see that Olympiad 7 months PFS, Embraca 8.6 months, TNT platinum very fast line. You just keep it in mind. In TNT very fast line, they are chemotherapy naive, and in the Olympiad second lines, Embraca third lines. But progression-free survival, you could see 7, 8.6, 6.8. ORR 60, 63, 8, 68. So now you should say when to use PARP or platinum. Number one, don't mention the financial crisis. Consider it as the academic issues. We know that we have financial constraint. So we should discuss in academic point of view. Limapa, you have to unmute yourself.
I think the overall response rate and the progression-free survival is very similar in Olympiad trial and TNT trial using olaparib and carboplatin. So there is not huge difference, and there is no overall survival benefit by using Olympiad olaparib. So in a metastatic setup, when we can't cure the patient, our first focus is the overall survival. If we improve the overall survival a little bit, I will definitely go for that. So as there is no overall survival benefit in olaparib, I'm not very big fan of giving olaparib in the metastatic setting in the first line. So I'm quite clear about that.
Okay. So regarding these issues, so still you are in favor of carboplatin. So very correct. So thank you all the what should I say, our senior teachers for giving their precious time. Now I would
one
like
thing, you have
yes,
highlighted all the TNBC cases, but this Olympiad trial also focused the role of PARP inhibitor in hormone receptor positive cases also.
okay.
Yes.
Okay. So there is options for, but though in the Olympiad trial the hormone positive group is around 20-25%, but we have an option for hormone positive groups. But due to the time constant, because there is a long discussion, you could say that adjuvant setup, there is hormone, there is CDK4/6 inhibitor, and along now come with the PARP. Is long discussion will be there. So I intentionally skip that area. But in the trial, definitely very hormone wasn't the hard to. So thank you. Now I like to request first, Tapal, a few words. Shanta, can you hear me? Shanta,
Assalamu
can you
alaikum,
hear
sir.
me?
Very good afternoon, sir. Honorable sir and madam, distinguished panel of experts, moderated and participated all respected oncologists. I would like to thanks and express our gratitude for your continuous support to us and conviction on the quality medicines of Everest Pharmaceuticals Limited. It is always a pleasure for us to be associated with Oncology Club Bangladesh in pursuit of medicinal excellence through CME seminars, conference, or research purpose. We are glad to be associated with this seminar on role of PARP inhibitors in for breast cancer. On behalf of Everest Pharmaceuticals, I am Shantapal, DGM Marketing. Would like to extend my hearty vote of thanks to the chairperson, Professor Abdul Hai sir, though he is not present today. Oh,
Sir is present.
Sir is there.
I'm
Sir is
brave.
there.
Sir is there.
I was a
present.
bit late
Okay,
for
sir.
10 minutes.
Assalamu alaikum, sir.
Walaikum
Thank you, sir.
With a
for
very
gracing
nice
today's
shirt,
webinar,
wearing a
sir,
very nice shirt,
and
sir.
encouraging us. Yes, sir. Sir is always evergreen. I would like to express my sincere thanks to all my favorite renowned panel of experts, Professor Dr. Mufaddal Hossain sir, Dr. P.A. Banu, Parveen Akhtar Banu madam, Dr. F.M. Kamaluddin sir, and special thanks to Shaida Lima madam, and not and last of all, our moderator, Dr. Mustafa Aziz Shuman sir, for sharing all of your knowledge and practical experience regarding olaparib or other carboplatin or recent updates and your personal findings. I'm very much glad and happy to be a part of this seminar. Last of all, I always expect your kind support regarding our targeted therapies of Everest Pharmaceuticals Limited, and so your all supports is much more valuable for us. So thank you all. So please.
Thank you, Shanta. Now I would like to request our chairperson, Professor M.A. Hai sir, Chairman of Oncology Club. Sir, you have to give a conclusive marks because we are discussing today a very new issues. So now you have to show the path, sir. Thank you.
Thank you, Dr. Suman. Heartfelt thanks to all of you, all the members who are taking part in this. And that is our suppress. I mean, thanks to Antapol of Everest organizing this. So, you could see that his part is a good drug, but will better for it. For breast cancer particularly, that I gathered from your discussions. I'm the oldest man, the oldest teachers of everybody. As Mufajal said, is student. I have nothing to say, but I'm teacher. So thank you all very much. It's a nice afternoon. We had a nice discussion. Hopefully this type of discussion will have to continue. I'm already continuing. Oncology class is always there. Nice things like that. And thank you all very much. It's all right. I have nothing to say. I've heard everything, excepting 10 minutes time in the beginning. And then I have heard everything. Saida was very much fond of carboplatin.
Cheap, sir, always cheap drug, cheap options, sir. Very cheap doctor.
That's a good drug, no problem.
Very good tracks. Very good tracks. Huh?
Okay, thank you all very much. Goodbye everybody. Assalamu alaikum.
So thank you. Thank you.
And Shumon, one information might surprise you. In the brightness trial, there is more death in the paclitaxel alone arm, that is 30%. And in the carboplatin arm, that is 10%. And veliparib, that was 12%. So we shouldn't scare so much to the carboplatin.
No. The carboplatin is a very good drug, and very, very effective drug.
These are all statistics.
Yes.
These are all statistics. Don't forget that.
Shuman, I think one important point we forget to discuss, that in this era of precision medicine, the testing is very important. Just getting a report of BRCA1 and 2 positive or negative is not enough. So the company like Everest should be working on this area, because unfortunately in our country, we don't have an accredited laboratory who are giving reports. So sometimes we are doing wrong treatment by getting a positive report, or sometimes by getting a negative report, we are missing the opportunity. So if you look at the details of the BRCA testing in this study, they do. Sometimes in our country, probably we are not getting that information, that much details information. So I think this is another point. Whenever we are choosing a drug like olaparib or rejecting a drug, we should be very cautious about this testing report, how much reliable it is. Otherwise, we may land up in a wrong conclusion. Thank you.
Correct.
Thank you. So thank you all the panel of experts, our teachers, for giving their precious time. Thank you, sir. Thank you, Everest Pharma, for
Thank you. Goodbye.
Bye, everybody.
Thank you. Assalamu alaikum.